All right, it's 11 a.m. and I would like to start. Esteemed colleagues, thank you for joining me in my little webinar. It is my great pleasure to introduce you to the psychedelic renaissance and in particular psychedelic-assisted therapy. It's a very complex area, very suddenly it's become very, very complex with growing research in clinical applications, policy, research, business and economics in particular, and corporations. Finally, the rapid change is a change in our consciousness itself, how we view ourselves and how we view the people that we treat. I'm not going to give you a scientifically rigorous presentation because it's just informal for myself and my colleagues. So I'm going to provide more of a narrative. I'm going pretty broad. I'm presenting on a number of areas that are just too broad to cover reasonably in such a short period of time. And I would just like to say that I am broadcasting from Thornhill. And Thornhill sits on the traditional lands of the Mississauga of the Credit Aboriginal peoples. And the reason that's important is because they actually never gave up their lands. So I would just like to acknowledge that. So let's start with the first slide. The first wave of research with MDMA and LSD and other psychedelics started in 1914 MDMA was patented in 1914 by Merck, a pharmaceutical company in Europe. LSD was discovered in 1938 by Albert Hofmann, and Hofmann distributed it widely to all of his contacts all over Europe and North America, widely and freely studied right from the 1920s to the 1970s, and in the 50s, 60s was where the bulk of the research, clinical research took place. In the 1950s, magic mushrooms left the mountains of Oaxaca and came to New York City by a banker called Wasson. His wife was an anthropologist, and she's the one that discovered it, and he brought it into North America. So these psychedelic compounds have been used as an adjunct for psychotherapy for many, many decades. But what happened is in the 1960s, these drugs, these compounds escaped from research settings and entered into the community. There was widespread, unregulated, chaotic use outside of medical settings, and there was a very significant social impact, especially on the youth in the 1960s. In response, the American administration of the day made these drugs controlled and scheduled them in the early 1970s. That's when the war on drugs was declared, and MDMA, psilocybin, LSD, and a number of psychedelic studies became illegal Schedule I substances. I'll explain what that means for those of you that are not familiar. So the impact of this was that very valuable and promising research with these mind-altering substances came to an abrupt end. But we are not the center of the universe, so this research continued in some countries in the US and in other countries in South America and what have you. So just so you're informed, Schedule 1 to 5. Schedule 1 means that that drug has a high potential for abuse and it has no medical use whatsoever. And LSD and MDMA and psilocybin are in that category. And I'm going to do my very best to convince you that that is absolutely not true. And these schedules need to shift. Schedule 2 means that there is abuse potential and a potential for dependence. Okay, you reading this? OxyContin and fentanyl, according to current scheduling, have potential. LSD is not addictive at all. Neither is MDMA. Schedule 3 means that it has abuse potential, hydrocodone, ketamine. Ketamine can be addictive for sure. Schedule 4 means that there's low potential abuse, drugs like Xanax, Ativan. I work with a lot of people that have trauma and just try and convince them to reduce their Ativan. Won't happen. So Schedule 5 means that there's a low potential for abuse, and these are over-the-counter cough syrups and whatnot. So let's talk about what psychedelic actually means. Psyche means mind, delic means to manifest. So psychedelics are mind revealing or mind manifesting medicines. They take us into what is referred in the literature as non-ordinary states of consciousness or non-dual consciousness. I personally prefer expanded state of consciousness because it takes into naturally occurring expanded states of consciousness we have, like hypnosis and dreams. Once you are in an expanded state under the influence, you will travel to, people report that they travel to dimensions, they do time travel, they encounter beings and entities from other planets, other dimensions. They may have a life review. They may come back with deep insights about their own lives. They may have, if you're really lucky, you may have an ego death or a peak experience, which is like an encounter with the divine. So arguably this man, Rick Doblin, Dr. Rick Doblin, has been at the forefront and is the face of the psychedelic renaissance. This is the second wave. So the first wave ended in 1970, and the second wave started when Rick Doblin started a public benefit corporation a long time ago called MAPS, the Multidisciplinary Association for Psychedelic Studies. So he, for 20 years, devoted his life to fundraising, raised $50–60 million privately, and started phase 1 studies in the 80s, graduated to phase 2 studies in 2004, and phase 3 studies started in 2018. MAP studies MDMA and PTSD. So currently, MAPS is doing phase 3 studies internationally, including Canada. So switching now to psilocybin, psilocybin is now in phase 2 clinical trials. Compass Pathways, now owned by Atai Life Sciences. These studies, phase 2 studies, are currently underway in Canada at CAMH. There's some delays due to COVID and other things, so we're hoping to get started very, very soon. Compass is all over the place. They're in the USA, they're in Israel, Ireland, Spain, and several other countries. Phase 3 trials have not started yet for psilocybin. The phase 3 trials is the final phase that will be required by the FDA and Health Canada to approve psilocybin therapy as a legal prescription treatment for treatment-resistant depression. Compass studies specific to treatment-resistant depression. And I have to tell you, I have the very great honor of having a principal investigator here. I hope he's here, Dr. Hussein, and as well my co-therapist, Dr. Ofer Finkelstein. I'll introduce them at the end, and yeah, you should meet the clinical team at CAMH. So psychedelic-assisted therapy, the principles that we use now were developed in the 1950s, 60s, and 70s, and form the basis of the work that we do now. The contributions have been by many, many therapists. It's multidisciplinary, I have to say, from pharmacists to psychiatrists to psychologists to Reiki masters to all kinds of things. The therapy that I have been trained in differs very, very much from current evidence-based therapies that we used. It has nothing to do with CBT. You cannot use that paradigm in an expanded state. Afterwards, yes, but not during. The therapy itself is very non-directive, it's very non-interpretive. The therapists are very non-invasive and just basically remains an empathic witness to the journey. So I chose this slide because I can swim okay, but I get nervous in deep water. So the philosophy in the actual therapy that Dr. Finkelstein and I will be providing is that less support is more support in these expanded states. We will give you the message, if you're a volunteer with us, we will give you the message that the source of your healing is inside of you, and we will redirect you back to the inner experience that is unfolding under the influence. We will teach you breathing techniques and other grounding techniques to help calm you. I can tell you, we don't do body work with the Compass Trust. There's no touching. We can't touch below the shoulder. You can hold hands, but in other applications at CIIS, I can tell you that energy work, body work, dance, art, all of this is all part of the integration process. It's just not part of the research studies for a lot of reasons. Music is a critical component of the journey, and I'll talk a little bit more about that because that's just as important as the therapy and the medicine. It's quite interesting how all of these work together very synergistically. If you are lucky enough to be selected and meet the criteria for the study, we will spend the entire whole day with you. You contract to be there for 6 hours. We could be there as long as 8 hours. I remember when I got my training in London, England, we were there 13 hours because something unexpected happened and we just have to stick around. And then after your dose, the integration sessions start, and that's part of the process. I talked about how music played a very critical role. It's been used since the 1950s, and this is an entire exploding area of research just onto itself, the effects of music in the brain, and in particular, the effects of music and sounds on where the journey will take you. The music will take you in many different directions on your journey. Music can facilitate emotional release. It can facilitate a mystical experience, which is what we're after. It can facilitate autobiographical insight if you've done a review. It's very important to like and resonate the music that is part of your journey. We will play music for you for the full duration of the journey. We have had instances where people have said, I don't like that music, can you turn it off? And as therapists, Dr. Finkelstein and I will have to make a decision about, are you avoiding something internal that's going on habitually, or do you really not like the music? The music that Compass Pathways plays is quite similar to the music that Johns Hopkins University plays. Not my personal favorite, but it is part of the study. And it was very carefully selected. I can tell you tons of hours of research went into selecting the exact pieces that were used and in sequence. So there's several phases to a journey. We build you up, and then you have your peak, and then you have to come down. Safety procedures are, well, I think Dr. Hossein could probably speak to this. He is responsible for the screening of the participants. That burden falls on his shoulders. And boy, the research requirements are really rigorous. People at the 11th hour can get bumped for any reason at all. Set and setting refers to, set refers to your preparation. We will prepare you very thoroughly. We will have a little bit of an idea of what brings you to this medicine, what past traumas have you experienced that might emerge that we're prepared for. And then during that process and preparing you for the set, we will teach you breathing exercises, visualization exercises, whatever you need. We just have a whole toolbox of things to help you out with that. The training of the therapists is rigorous. So after I did my doctorate, I spent a year in California with the California Institute for Integral Studies. That was a 1-year-long program. And then I did another year of training with Compass, which was a gift. It was awesome. So throughout the journey, if you're a participant, we will prepare you and we will support you throughout. We will monitor you throughout. We do have emergency protocols and aftercare in place for participants in the event of an adverse event. And as far as I know, there haven't been any, as far as I know, I don't think so. So the effects of the journey, there's a temporary reduction in fear. There is an increase in positive emotion towards self and others. There is increased interpersonal trust. There is an emergence of feelings of empathy, deep love, and deep appreciation. It doesn't matter whether you're with your therapist that you have these feelings for, or a tree. It's kind of indiscriminate, these feelings. So I think that has some really wonderful applications. There are some studies going on or scheduled to start with PTSD, where one partner has PTSD and the other one does not. So both couples take the medicine. This is MDMA. I'm switching now to MAPS, but I think that has a great promise. I'm looking forward to the results of that. After the journey, you have a clearer perspective of the trauma as a past event. So I'll talk about pharmacokinetics and brain impact just a little tiny bit, but it's really quite remarkable to see when someone revisits a horrible memory, like horrible memory, and they can come back literally at the end of the journey and see it differently. Now, because of this presentation, I wanted to do so much. I did have some data in my other presentation on phase 1 and phase 2. And the interesting thing is that at 24 hours, there was a 38% reduction in trauma symptoms, or 38% of people did not meet criteria for PTSD. And then several months follow-up, that increased to 68%. So that suggests that with integration anyway, you can continue to improve. So even after 24 hours, if your symptoms have not alleviated on a temporary basis, then they may continue to do so. And I just from a brain point of view, I find that really, really interesting. I'm not going to spend a lot of time on this slide, but what is the therapeutic process catalyzed by? And we think it has to do with the ability of the volunteer, the participant, to stay emotionally engaged while revisiting the traumatic experience. If you work with trauma, you know that avoidance is, very difficult to get past. People are able to view their trauma without becoming overwhelmed. So you can view, and there's a decoupling of the emotional reaction to whatever it is you're revisiting in your consciousness. We really try to avoid dissociation and emotional numbing, which is what happens in ordinary states of consciousness when people do not get past their trauma from the past. So we capitalize on the heightened state of empathic rapport. It may facilitate the therapeutic process. We work very differently. I can tell you with the people that I've worked with, they really like it because we don't work in the cognitive realm. We work with body sensations and redirecting you back to your own inner experience. Okay, so this brings up the hard problem of consciousness. What is it? We don't really know. There's lots of ideas out there. One of the people I follow and have for very many years is Eckhart Tolle. And he says the secret to life is to die before you die. That sounds like gibberish, but it's not. It makes sense makes complete sense. And if you are in an expanded state of consciousness, you get it. Whereas it just sounds like gibberish if you don't get it. There are also my personal favorite, Rumi, constructs change. Out beyond notions of rightness and wrongness is a field. I'll meet you there. So what was before was wrong may not be so wrong, and what was right may not be so right afterwards once you've had an experience of expanded consciousness. Beliefs may change. St. Francis of Assisi said, and it is in dying to the self that we are born to eternal life. So there's something about dying and being reborn and consciousness. So let's talk a little bit about expanded states of consciousness and what is that? You can have an expanded state of consciousness very spontaneously. All religions of the world, all ages around the world have had spontaneous, not religious people, just ordinary people have had extraordinary visionary experiences or religious experiences. If you are a religious person, you can have a mystical experience, you can have an archetypal experience. These are known all around the world in all of the major religions. You can also acquire skills in expanded state of consciousness. If you spend your life meditating 20 years or more, you'll get there. The research shows that the brainwave activity of experienced meditators, these are Tibetan meditators with their lifetime of meditating, their brainwave activity resembles the brainwave activity of someone under the influence of psychedelic medicines. And interestingly, this brainwave activity resembles the brainwave activity of very young children. Fascinating stuff. You can also enter into expanded states of consciousness quite naturally. We do it every single night when we go to sleep. In sleep, we can meet other beings, we can time travel, we can do things that just simply don't exist in ordinary waking consciousness. So now, you can also get into an expanded state of consciousness by using psychedelic medicines like psilocybin, ayahuasca, LSD, mescaline, ibogaine, MDMA, 5-MeO, DMT, and peyote, all kinds of things. They will all take you to the same place of expanded consciousness, or at least have the potential to. Using psychedelics can be very, very challenging. It's very influenced by the dose that you take. the medicine that you take. So for example, with the effects of MDMA, for example, I see a really good application in interpersonal settings. MDMA may not take you to a peak experience, so it may not be, not necessarily, it may not be ideal for certain types of issues that people are struggling with. The set really matters. If you go in without having really reflected on your intention, so intentionality becomes very, very important here in terms of the goals. And because we're working with treatment-resistant trauma and treatment-resistant depression, people have tried everything, and therefore they're very vulnerable. We're very respectful around approaching them. And one of the things that I am very careful about is managing people's expectations, because being disappointed at the end can be much harder for someone with treatment-resistant depression than someone who is just using this recreationally. Setting matters. I do know of people that are ordering ayahuasca online and getting high in their dorms. That's probably not going to bring you any kind of awareness or insight, but it is happening, and age matters as well. So I guess the older you are, the more life you've lived to review. So the most challenging experiences can turn out to be the most beneficial for you. Research in this area is not necessarily aligning to ICD-10 codes or DSM codes. We are addressing more universal issues, our fears that are at the core of our mental illness problems. The medicine will address themes of grief in your life that remains unresolved. If you have a diagnosis of terminal cancer, it addresses your mortality issues, fears in general, the fear of going insane. If you're older, you have a diagnosis of Alzheimer's. I can't imagine how terrifying that might be. We have a lot of seniors currently all over the world, not just here. Many of them are quite terrified of isolation, being alone, dying alone, living their lives alone. Physical distress, the older you are, the more likely you are to have a diagnosis of some kind that's going to end up in being on some medication or the other, or having some physical limitation or the other. Pain is a big thing. And who makes it into, senior years without multiple losses? So what do we do with all of these fears? What are we going to do with the medicine? We are going to go into the monster. That's what we do. We help you along the way, but this journey is yours. And that's what makes it challenging. And I also have, during this time, when people are very, very distressed, that's when the therapists that are available, there's always two therapists in a formal setting or an informed setting, there's always two therapists. We will help you through that journey. We will remind you to breathe through it. We will give you lots and lots of suggestions about how to cope. We will never tell you what to do. It's very non-directive. So we will direct you back. Also in the audience, I hope he's here, Dr. Kevin Smith. I invited him. Dr. Kevin Smith is an anesthetist. I'll invite him to say hello in a bit. We have a client in common, and I was going to tell the story, but I'm going to let him tell the story. We were talking about someone, and I made the comment about dying, so I hope he tells that story. So what happens once you've gone into the monster? For sure, you will survive. These are pretty safe medications, medicines. And after you have gone into the monster, you conquer yourself. You can kiss your enemies. You can swim with your enemies. You can walk peacefully with predators, previous predators. And if you're really, at a certain age, maybe you will raise your child to live in a more expanded way. I love what Joseph Campbell said. He says, I don't have to have faith. I have experience, and the experience will change you if you have an experience with these medicines in a really safe and respectful, loving way. I really like what Houston Smith has to say. The human opportunity is to transform flashes of illumination into abiding light. So what happens when you journey is you'll get a flash, and when you come back, depending on the dose you've taken, you won't remember most of it. You won't remember it. You'll just remember the feeling of bliss. And it's that flash of light that we want you to bring back. It's a feeling we want you to bring back. And that's what we work with in integrating that feeling into your life after you are born again. Sounds awfully religious, doesn't it? Okay, so what happens after you have conquered yourself? Well, then you integrate. Edward Hopper said, if you could say it in words, there would be no reason to paint. And this is the reason that integration is not necessarily sitting down and having a conversation with the therapist that's that for you. We may recommend that you do drumming, or you may do dance, or you go for a massage, or you do body work, or you take a forced bath, or you walk bare feet in your backyard. We address cognitive, emotional, interpersonal, physical, and in fact, spiritual aspects of your being in the integration, because all of those areas will be hit. So what happens once you've integrated? Well, what happens is if you change the way you look at things, the things you look at change. It's really that simple. The less you do, the better. The less I do, the better, which is kind of very different from our traditional models. So what causes this enormous, radical, sudden, magical shift? Well, we think the brain has something to do with it. So this is the, you can see here a little spider in the eyes. So all information that is fearful to us, that we find threatening, goes in through the amygdala, and then it goes distributed through the rest of the brain. We think that there are a number of possible mechanisms. The fear circuitry actually involves the amygdala, the hypothalamus, the periductal ray. Also involved in the neurocircuitry model is the ventral medial prefrontal cortex. This is the area of the brain that, for you psychologists, gives you the appraisal of the stimulus. It processes risk and fear, and it regulates amygdala activity. So we know that dysfunction in the prefrontal cortex plays a significant role in depression, anxiety, and trauma. And what happens with this medicine is that the amygdala, when you're afraid, amygdala activity becomes disinhibited, leaving you with the subjective experience of fear or dread or whatever. So I'm going to talk a little bit about the PET study I do have. So what are the pharmacokinetic, pharmacological effects of this? Well, what's happening in the brain is these medicines release massive amounts of serotonin into the brain. And the medicines, almost all psychedelics, not all, but almost all psychedelics have a particular affinity for a very particular receptor, the 5-HT2A receptor in the cortical area of the brain. It does occupy other receptors, but this seems to be a favorite of all of the psychedelics. Simultaneously, there is an increase in neurohormones. There's oxytocin being released into your body. You know, that's the attachment bonding hormone, promotes feelings of trust, bonding, affiliation. Prolactin is also released. So if you're a woman, you've had a baby and you're nursing, these hormones are involved. Subjective effects are a deep sense of relaxation and receptivity to whatever's going on around you. So my next slide is, this is what brought me to this research, because I have to say I was this is my 30th year of practicing, and I've been a pretty mainstream practitioner for 26 of those years. So this is a slide, we believe. Previously, it was believed that neurogenesis stopped in adulthood. In mammals, this man, Jordi Riba from Barcelona, Spain, in Open Science, has found that neurogenesis actually does continue in the hippocampus into adulthood. For neurogenesis, for those of you that are not familiar, there's very briefly, there's three stages of neurogenesis. First, there's proliferation of the stem cell. There's just growth. Then there's migration. The stem cell has to go somewhere in the brain. And then there's differentiation, where the cell turns into a fully functioning neuron with dendrites and axons and all that stuff. So I'm not going to spend a lot of time on this. He studied ayahuasca, and ayahuasca breaks down into two compounds, harmine and harmaline. Harmine seems to stimulate stem cell growth, and harmaline seems to affect dendritic growth. The reason I bring this up is because give it 3, 4, 5, 10 years, and this is going to have insane implications for brain disease, Alzheimer's, Parkinson's, and acquired brain injuries, mild traumatic brain injuries, and all of that stuff. So moving on, this is your brain on psilocybin. This slide comes out of the laboratories of Robin Carhart Harris from Imperial College. This is an MRI composite of a small n of depressed people. So this is, on the left is your resting state brain. This is a composite of the communication, the neural communication pathways in the brain. On the left, you can see that, you know, the older we get, the more constrained our brains become. And as a result, we become more fixed in our ways behaviorally and functionally. And you can see that on the brain on the left. These patterns of speaking are completely familiar and repetitive. They're the same number, they're an equal number of lines on the left image as they are on the right. On the right is a brain MRI on psilocybin. So this is a brain like gone amok. So what's really happening here, if I can get metaphorical on you, is that parts of the brain are talking to other parts of the brain that have never had a conversation before. And when parts of your brain start talking to other parts of the brain, that seems to lead to insight and integration. So this is your brain on LSD. Anyone want to give it a shot? What's going on here? Anyone want to put their hand up and give it a shot? No. Okay, so this is LSD. This image comes out of the laboratories of Professor David Nutt from Imperial College in London as well. He's a neuropsychologist. This is a scan of the visual cortex. You can see on the left on placebo, some activity going on here, not a lot. Take LSD and all of a sudden the visual cortex is talking to the frontal, like all over the brain. There's communication, there's blood flow everywhere. Next is psilocybin. There's a lot of research. If I had my act together, I would have sent you some links, but I didn't. So Johns Hopkins University is the go-to place for psilocybin. They have just started a Center for Consciousness Studies. There's so many universities in the United States that are on this research. So they're known for their end of cancer and end of life anxiety. They are known for their protocols for addiction, smoking, nicotine and alcohol cessation studies, depression and PTSD. I can tell you that Google Aquino Center. So my cohort in 2018 included 2 oncologists, Manish and Paul, and they got together with Ron Miss, who's a philanthropist. He's just a very rich guy. And he financed the Aquino Center, or organized the financing for the Aquino Center, where this hospitals are private in the US, and this is owned by a religious group, the Latter-day Saints. So these oncologists convinced this hospital to open up a center where they are offering psilocybin-assisted therapy for the entire family and the person that is diagnosed. Very quickly, this is ayahuasca. Lots of studies in the use of in addiction, particularly cocaine and heroin, treatment for PTSD, depression. It's used for personal growth. These medicines come to us from indigenous cultures around the world. These medicines have been used in ceremony for thousands and thousands of years. So our Aboriginal people know a whole lot about these drugs, and we're just beginning to learn. So this is my personal favorite, Ibogaine. This is the godfather of all psychedelics. I love this medicine. What Ibogaine does that is different from the other psychedelics is that Ibogaine occupies most of the serotonin receptors in your brain, as well as the dopamine receptors and GABA receptors. There is a problem with this. It packs a punch, but it does have toxicity. it elongates the QT interval, which will mess up your heart rhythm and you could die. So this is, it doesn't happen often, but it has happened. And for this reason, I feel very, very strongly that this particular medicine is unlike the others, and it can only be administered in a medical setting. You must be cleared by a cardiologist. Make sure you don't have any heart issues at all. Your family physician should be involved. There should be a nurse practitioner available at all times, and then your therapist. So these centers are available in other countries, and I'll comment on what's happening with centers opening up all over the place. I have to say, it was Ibogaine was unregulated in Canada until 2017. There was a death somewhere in some unregulated place, and then Health Canada said, no, we're shutting it down. So in Vancouver and even in Toronto, a number of Ibogaine clinics popped up. They were not legitimate Ibogaine clinics. They were just people that were using Ibogaine. I was invited last year to be part of a panel discussion on a movie that came out about Ibogaine that Gabor Mate was involved in. I was a little reluctant to be part of a panel on a movie I hadn't seen, but I did it anyway because I just love this stuff. And when I saw the movie, it's winning all kinds of awards. I can tell you that is a movie about what not to do. That is absolutely about what not to do. I didn't like the movie at all, and I don't think it did any justice at all to what is possible with these and other compounds. This brings us to ketamine. Ketamine is an anesthetic. It's relatively safe compared to other anesthetics. It's most often used in children's surgeries. Effects of ketamine are dose dependent. I feel very embarrassed talking about ketamine when Dr. Smith is here, and he's an expert. It's currently available and it's legal, primarily used for pain syndromes, and it can only be administered under medical supervision, IM, IV in a clinic. Off-label ketamine is now being used. Low-dose ketamine is being used. Ketamine is not a psychedelic. No matter what people would tell you, it is not a psychedelic. It has psychedelic properties, but it is an anesthetic. The reason we use it in psychotherapy is because it deepens inner reflection, which is what we want. So low dose enhanced ketamine is being used all over the place. They're like on every corner. There's a ketamine therapy clinic in the US. Well, maybe not on every corner. I can tell you from 4 or 5 weeks ago when I came out and disclosed that I'm involved in this research, 4 ketamine clinics have popped up in Toronto, and I have concerns about that. So it's used off-label for many, many things. Psychotherapy, the psychotherapy component, because it's not CBT, it will deepen the subjective effects of ketamine. Low dose, you just stay home and it's linked to depression. I did talk about how it's unique to, the therapy is unique to expanded states of consciousness, and you must work with a physician. I have this is really 20 seconds, so I'm gonna play this if I can. This is James. He was part of the MDMA study out of Mass, and this is a 1-minute video about how it impacted him, and I thought it would be better to hear it from the horse's mouth than from me.
Being a medic in the military was the best and worst job I've ever had in my life. Especially deploying to Afghanistan, coming back, even though there was a lot of negative, there's a lot of positive. I didn't feel anything. I was so numb. I knew I loved my wife, but I couldn't feel it. I knew I loved my mother and father, but I couldn't feel it. And just kind of lost hope until I found MDMA. It was as if the MDMA was a light so I could see, and the therapists were people down there with me. And with a combination of the light and the therapist, I was able to find my way out of the darkness. And for the first time, like 2 years, I felt relaxed. I felt calm. I felt love towards my wife, which I didn't feel for like 2.5 years for my parents. This has been the most effective treatment I've ever done. And that was 3 years ago since my last session. And I'm still in control of my life. I can still feel, I can still relax. And I'm so grateful for that.
All right. So the path ahead, I believe, is narrow and precipitous. And yeah, we who serve the medicine stand united in our strict integrity and agreement to only engage in lawful activity for which we are duly trained. Where we are today in the advancements of these mysterious substances is due to the indigenous tradition keepers and contemporary urban shamans in the guise of physicians, researchers, therapists, educators, writers, artists, and other psychonauts. The war on drugs has been a war on us, as I believe all wars are, and we support the lawful and transparent use of these medicines in research-related activity for treatment, education, and harm reduction purposes. I believe the only way out is in, and on that note, I would like to thank you. It has been a great pleasure to spend time with you, and I have expanded your consciousness just a little bit, and now we are going to go to Q&A, and I'm going to end my slideshow. Okay. Olivia, how do I get myself back to me? Do I stop the share? Yes, looks like it worked. Okay, so we have some time. Go ahead, Betty.
Oh, okay. I didn't think I'd raised my hand, but I definitely wanted to say something. So that's really very interesting that you picked up on that. I'm really curious about the music, because it seems to me that this experience needs to be self-guided, where the person needs to go into whatever part of themselves they enter in and follow out their own path, their own journey. And that the music is a structure. And it's not a structure that's coming from the person. It's an externally imposed structure. So I'm very curious about that.
Well, that's why I mentioned that music is very, very pivotal. It can change your experience. So it is an area of research. I can tell you that I find that the compass music is very heavily influenced by classical music, and there's a lot of research on classical music and the effects on the brain, so it has been very strategically been selected. But I think the more novel your experience is, the better. In other settings, you will hear music and sounds you've never heard before, and that I think is very important rather than hearing familiar sounds, because it activates different parts of the brain. And classical music, depending on your experience, can have personal associations. We don't want that. We want novel associations.
Right.
Thank you for that, Betty. Any other questions or comments, anything? Well, quiet group. So what I would like to do now, since I'm not seeing any hands up, Dr. Smith, can I introduce you just to say hello? There you go. Hello. So nice to join you. I'm very curious to hear what is your reaction to this medicine.
Well, I find this fascinating. I know very little about it, quite honestly, but it doesn't surprise me given what we see in pain medicine with the effects of various medicinal agents on not only patients' pain perception, but also their mental wellness. And we've certainly perceived, long before the studies on depression and ketamine, we've recognized that effect just on a day-to-day basis in using ketamine for chronic neuropathic pain management. So if ketamine, why not other psychoactive substances? It's just a matter of time when, sorry, just give me one sec.
So it happens. So I'm going to tell you a quick story. So Dr. Smith and I have, oh, Dr. Smith, you're back. Okay, go ahead, please finish.
So I was just going to say, it's just a matter of time that science catches up to all of this, but it's not a surprise that the psychedelics also have medicinal properties and, far beyond ceremonial purpose. But I'm quite interested to follow along and learn more about it as it progresses. Similarly, how cannabis took off in the medical world after being sort of judged as a pure recreational substance, but clearly with medicinal properties that are only being evident through controlled research in recent years, but people have known it for a lot longer.
Right. Thank you for that very much for checking in. I'm wondering if Dr. Finkelstein is here, my co-therapist at CAMH, and Dr. Hussain, who's our principal investigator. If you're here, gentlemen, could you wave or come on?
Yeah, hi to everyone. I had some technological problem, but eventually I got in. So thank you for that, Don, for the invitation and for the interesting talk and presentation. My name is Ofer Finkelstein. I'm a psychiatrist from Israel. I came here as a clinical fellow to CAMH. My interest was to study psychedelics and is the Renaissance in psychiatry. And it was like the opportunity became even better, the option to join Dawn as a co-therapist. It was not the plan in the beginning, but I'm very happy that the way it came. I can say from my perspective that I have great interest in the altered states of consciousness as a source of therapy or new options for therapy. I just saw this documentary about Richard Schulte, this ethnobotanist who traveled to the Amazon and Mexico in the early 20th century to learn about the indigenous people and use of substances, initially looking for curare, actually, that muscle relaxant used in surgery. And I don't know, I probably am not the first of thinking about the analogy of that, but I guess curare did a tremendous change to the surgery field in medicine, allowing the patient to do it muscle relaxant and having much better approach for the surgeons. So I thought maybe the same plants or idea would do a change for the psychotherapy and mental health for the human race, offering this again the easier approach to the unconscious and to the understanding of the mind and consciousness. Hopefully, with offering a greater option of treatment to our patient. As a psychiatrist, I can see the limitation of the therapy as it is today, and so I hope this new frontier will be promising as it looks. I still want to emphasize from the things Dawn said, and also from the approach I come with, and doing that in CAMH and research setting, that having a very cautious attitude, I think, is very important. Not to rush with this approach. I think there is also many risks in psychedelics for some people that we are still not familiar enough with. So it's a very important gentle dance of moving forward and then maybe backward and forward very gently in order those substances and this medical option can develop in a proper way and offer more good than bad. Thank you.
Thank you, Ofer, very much. I'm wondering if Dr. Ishrat Hussain is with us. Olivia, if you could just shout out, it was a last minute thing. I'm not sure if he was able to make it.
I'm not sure. Right. He's logged on, Dr. Don.
Okay. Olivia, do we have any other questions or anything in the chat?
Yes, we do. So we have questions in regards of training opportunities for this psychedelic treatments and how the trainings would look or currently looks for those who want to provide this therapies.
Well, what I was going to do, depending on the interest, because there's a number of people here, is I was going to do a breakout room, because I see that there's opportunities in 3 areas. And part of what motivated me to do this webinar is really, what I see going on around me, as Dr. Finkelstein has emphasized, and as I emphasize, we have to proceed very, very carefully and cautiously. And it is being rapidly monetized, like so rapidly that it kind of concerns me. Actually, it really concerns me. So there are 3 breakout rooms I was thinking for those of us that are interested in research opportunities, you with individuals with an academic or hospital interests, research. We can do breakout 1 for people who are interested in clinical applications to expand their existing practices. We can go to breakout room 2. And the 3rd is business, corporation development, and just, getting involved in that whole thing. It's happening quite rapidly. So we have about 10 more minutes. And this was just something I thought of just so I could track how I can assist you best, who's interested in what. So I have at least 1 or 2 people interested in research applications and training. I don't know if everyone's interested in that, so we could do that in a breakout room. Any other questions that I can assess? So we're gonna do the poll.
I'm just launching the poll now, so it facilitates us breaking them up in different rooms. If you guys can answer that, then we will know where to go.
Yeah, I have to admit, I've never used a breakout room, so I don't know how to do that.
Oh, it'll be fine. It's very easy. You'll be invited. You just click, and then you'll be invited to return, and we'll close. It's
okay.
Very easy. And then I'll pop into each one of the rooms. Any other questions? Somebody's got to have a question.
Yes, so on the chat, we also had a question in regards of the approach on the youth, if the type of approach is inappropriate for our youth. And we also have a question in regards of ibogaine and what kind of offers we have available, what kind of treatment offers we have available. Okay,
well, I think you're on very dangerous territory when you start to talk about anyone under the age of 19. From a neuro perspective, my preference would be not to mess with anyone's brain until they're at least 25 to 28. But we also know simultaneously that if you're going to get into trouble, if you're going to derail your life, you're going to do it somewhere in that age range. Ceremonially, I can tell you that this medicine is used with very young children. I don't think that would fly with Health Canada. We can't work with adults that suffer. It's very, very tricky. I would consider it for someone that was legally able to drink with parental permission and involvement with the parent. This is a very inclusive thing because one person changes, everyone will change. That's how the dynamics work. I'm very interested in family applications myself. I work in family law. Parents fight horribly with one another. And so doing this medicine where your defenses and your hatred and your anger is reduced, and then you can calmly, without emotional hooking, talk about how to share your kids in 2 homes. That's important. So you can focus on your kids instead of your own pain and anger and all that stuff. So if you're interested in ketamine-assisted psychotherapy, expanding it into your own clinic, you have that option to join that breakout room, 1, 2, or 3.
We didn't get many or any.
Oh, okay.
One interested on the business and finance breakout room. I guess we're more focused on the clinic integration and research. So I'll just launch all 3 of them, and you guys can just click on.
Wait, Livia, before you do that, since we don't have that much interest, I can address the training and research. So I can tell you there are enormous training and research opportunities. CAMH, we're just winding down our Phase II clinical trials. When Phase III starts, we're going to need hundreds and hundreds and hundreds of therapists around the globe. There's a big recruitment going on. When I trained at CIIS in California in 2018, there were 68 of us that graduated. 2 years later, they've got a campus now in Boston. I have the very great honor of being a mentor to 9 psychiatrists, psychologists, clinical social workers, lawyers who are taking the training now. They have 400 registrants. They had 68 in 2018. That's how fast it's growing. And that's CIIS. MAPS is probably doing as much. Their training is very rigorous as well. You probably won't get hired to do this work unless you have done one of those two, although I'm not sure. I can tell you Compass does its own very rigorous training. Also, I can tell you that the research is now expanding. When I started, you had to have a PhD in psychology, be an MD psychiatrist, or a regulated healthcare provider at a doctoral level, because it was a postgraduate program. I looked at the roster recently, and they're opening it up for naturopaths. They're opening it up for registered psychotherapists, clinical social workers, because we need therapists. We're also finding that it's not so much your credentials that matter, but your therapist variables. It's your integrity as a human being that is more important than your credentials. We don't care about the credentials as much as we care about your relationship to this work. In terms of business, I can tell you I'm very concerned about what's happening in the business community. It's I listened to a debate between Rick Doblin and Bia Labate. Bia Labate is an anthropologist from South America, and Rick Doblin and Bia Labate are pro-legalization of pretty well everything. And then there was the dean of Johns Hopkins University Psychiatry Department, I don't remember his name, and a lawyer. And I have to say, I was swayed. I was very swayed by against legalization. I no longer support, I don't think I ever supported legalization. I think I support decriminalization much more so than legalization. And the lawyer said his concern was if we legalize mushrooms and these psychedelic medicines, then what will happen is that a handful of people will become filthy, obscenely rich, like what happened with cannabis. He was the lawyer that was involved in the deregulation of that. And you can count on one or two hands how many people got rich, and there was no significant benefit to the public. And as Dr. Smith was pointing out, it just got lumped into like a recreational thing. And cannabis is not an area of interest of mine. I don't know that it alters, at least I'm not aware of it, but the pattern remains the same. A handful of corporations are very, very rich. And yeah, and so we're concerned that that's happening now. I can tell you, I was talking earlier about these ibogaine clinics that popped up. People are so transformed. So what's happening in Mexico and other places, there was a Navy SEAL. He had trauma, he did ibogaine, he transformed, and he opened an ibogaine clinic with his wife. And now they've got all these Navy SEALs going there. I think hopefully he had all the right training, but he was a soldier, and now he's running an ibogaine clinic. And that's the story. That's what's happening. That was part of my motivation to coming out to my colleagues. You know, back in the day, even before my time, OHIP was willing to cover treatment from psychologists. They were willing to cover therapy. But the leadership at the time said, no, we want you to cover our testing as well. And OHIP said, see ya, take a hike. And so now here we are. We don't have coverage. So I want to proceed very, very carefully, because there are people who are negotiating with insurance companies to get this covered, to get the psychotherapy covered. So the family doc you work with, or someone who's licensed to provide scheduled medicines, does that as part of their regular practice. It's OHIP covered. We get coverage through insurance. I'm already actually doing it. I do have a physician that I work with that he does his thing. And then I work with my clients, and I do low dose ketamine. The other thing is ketamine clinics are opening up everywhere, and they're being run by businessmen who are not therapists. So the model is business. So I'm not happy with that pattern repeating itself. I really think I like the Oregon model, and I would like to see this medicine in the hands of clinicians who are duly trained to respect what we are doing. Because, you know, yeah, we all run our own clinics and money matters, but we don't put profits ahead of someone suffering. And I think for the people that I've met, we're all on board. We're all on board. We're all doing the same thing, but it's being taken over by really, really smart business people with a lot of money. So that's happening out there as well. Livia, you had a question.
Yes, more questions on the chat coming up. Can those with active addictions, psychosis, schizophrenia be candidates for treatment with psychedelics?
No, so that's part of the screening procedure. If you have had a psychotic episode or a schizophrenic break, either yourself or in the first generation, your family, parents, aunts, uncle, you're eliminated from the study. I personally wouldn't